Hello, today I'm going to talk about two topics. The first topic is immunotherapy in renal cell carcinoma. Definition: renal cell carcinoma is the rare type of urologic cancer and has a poor prognosis with 30% of metastatic patients at diagnosis.
Sunitinib is a standard first-line treatment for kidney cancer, but it's becoming decreasingly used in the first line. For these intermediate and high-risk patients right now, it's probably not the standard of care. The standard of care at Columbia and at other places, actually especially academic places, is combination immunotherapy with anti-PD-1 and anti-CTLA-4. So whether you'd get the same result with modern immunotherapy or not is a very good question, actually. The other thing is I can tell you that there have been preclinical studies and now clinical studies suggesting that you should give immunotherapy before surgery. There was a recent paper in the New England Journal of Medicine from the Hopkins Group showing that in lung cancer, giving immunotherapy before surgery is much more efficacious than giving it after surgery. We don't know whether that's the case in kidney cancer or not, but we do know that sunitinib in the adjuvant setting after surgery has generally not been helpful, actually. So the question is, if we gave immunotherapy before surgery and compared that to immunotherapy alone, what would be the readout? That is being tested to some degree in an ECOG trial at this point with nivolumab monotherapy. But it is an important question. Again, the two things are, if it was a different drug, if it was real immunotherapy, or if it was neoadjuvant treatment was applied, would yes still have the same result?
Application in medicine: renal cell carcinoma is a rare urological cancer representing 3% of all cancers in women and 5% in men, with an incidence of around 400,000 cases worldwide. The prognosis is poor. 30% of patients are metastatic at diagnosis and almost 0% of the remaining patients will develop a metastatic detected during the follow-up. Cell carcinomas represent the vast majority of RCC, around 75%. The other histologicals mainly encompass papillary (20%) and composite RCC (5%). The other antigens are very rare, including translocations, associated RCC, medullary RCC, and collecting duct carcinoma.
I think it's a truly exciting time. I mean, bladder cancer has been pretty much neglected for decades. We only had cytotoxic chemotherapy that had some modest efficacy, I would say, in patients, and now we are witnessing a true revolution with the approval of 5 immunotherapies. We're still, I think, working our way through in how to best identify patients who may benefit from these therapies and how to improve these therapies. But I think we are witnessing very durable responses in a subset of patients who can benefit from these therapies for years with really sometimes minimal side effects. I think this is truly gratifying for any medical oncologist. So kidney cancer has always been kind of like a immune responsive tumor. It's really the only other cancer where we have essentially old-fashioned immunotherapy a la high-dose interleukin-2, similar to what we use in melanoma, approved with long-term benefits. So since November 2015, we have nivolumab approved, a PD-1 inhibitor, and we do know that we can induce very durable responses in a small subset of patients, around 21% of patients. However, simply speaking, it's not enough. And I think the future is going to be to look at combination therapies. This will come forward in the short term, I would say, in 2 different flavors. One is the combination with VEGF inhibitors, and the other one in combination with another immune checkpoint inhibitor called CTLA-4 inhibitor or Yervoy. And I think we will witness in a very short amount of time how the first-line therapy for kidney cancer is going to be transformed. It's going to be driven by immunotherapy, truly.
Pros and cons: the treatment and management of metastatic RCC have radically changed over the past 20 years. Initial first-generation immunotherapy with cytokines, interleukins, or interferon represent started approached but with poor results. The development of tyrosine kinase inhibitor, mainly vascular endothelial growth factor receptor inhibitor, largely improved the prognosis of bad progression-free survival and overall survival.
So the things are clearly evolving for several years now, but especially since last ESMO, where we had the results of nivolumab versus everolimus randomized phase 3 study, which demonstrated that in patients who fail one or two VEGF-targeted therapy, there is a role for IO, immuno-oncology, and namely nivolumab. It is important because this is changing one of our standard of care, and since last year, this has been implemented in all the guidelines. What is important at this ESMO is that we're starting to have more information on which will be the next step in terms of combining those agents, for instance.
Usually applied in medicine in Ecuador, renal cancer constitutes 2 or 3% of all malignant pathologies. Of these, clear cell renal carcinoma corresponds to approximately 85%. Because this histopathological type is resistant to chemotherapy, new molecules are used for treatment worldwide, called targeted therapy, with significant results of progression-free survival and overall survival.
I think the most interesting data and the one that people are very excited about is the emotion 151 that we just heard from Dr. Bob Moser. And this is a phase 3 randomized trial that looks at bevacizumab with atezolizumab versus sunitinib in a phase 3 setting for advanced metastatic clear cell kidney cancer. So let me just give you a little background on how we treat kidney cancers or advanced kidney cancers. So certainly there has been a lot of landscape changes. In the past, if we go back even a decade ago, we really did not have a lot of systemic therapies to offer. But now we have VEGF inhibitors, so these are what we call the TKIs. And certainly we have the immunotherapy drugs, but mostly for second line right now. So with the advent of these trial, the landscape of treatment is really changing. So in this phase 3 trial, though, what they saw was a phenomenal and very compelling improvement in the progression-free survival. The overall survival is yet immature, but we are seeing that there is two co-primary endpoints. One is progression-free survival in patients who are PD-L1 positive, and in this population, there was about 40% of them, as well as an intent to treat population. And what they found was the PFS, for instance, for the combined therapy is in the order of 11.2 months, compared to only about 7 months for the sunitinib arm. So these are compelling data. And in terms of toxicity, actually there's not a whole lot that it's unexpected, if you will. So I think it's a fairly tolerable regimen. So I think moving forward, this is a great candidate. Perhaps, we will be seeing more this year. I think it's rapidly evolving. And the trial I just mentioned, the emotion trial, is but one of them. Last year at ESMO, we heard about the Checkmate 214 trial, which looked at the combination of nivolumab and ipilimumab versus, again, sunitinib, and that was also a positive trial. So we are starting to see now these combination IO drugs that are pretty soon going to be changing the landscape of treatment, because right now IO therapy has largely been second-line therapy with nivolumab. So I think we are starting to see these agents move up, and not just maybe single agents, but in combination.
Conclusion. With an increasing number of treatment options available, improved biomarkers are needed to better study patients and define the optimal selection of patients and the sequence of treatment to overcome resistance. Promising biomarkers such as gene expression signatures or gut gene expression signatures or gut microbiome are under evaluation. It is likely that the future of predictive biomarkers relies on the combination of different approaches reflecting the complexity of the TME. And the second topic is ribavirin for chronic hepatitis E virus infection in transplant receipt. Definition: Hepatitis E virus genotype 3 causes self-limiting infection in non-immunocompromised patients. However, it can lead to chronic hepatitis and cirrhosis in patients who have received solid organ transplants, patients with human immunodeficiency virus infection, and patients with hematological cancer who are receiving chemotherapy.
Hepatitis E is RNA virus. Spread by the fecal-oral route. Incubation period 3 to 8 weeks. Common in Central and Southeast Asia, North and West Africa, and in Mexico. Causes a similar disease to hepatitis A, but carries a significant mortality, about 20% during pregnancy. In general, hepatitis E is a self-limiting viral infection followed by recovery. Prolonged viremia or fecal shedding are unusual. In acute infection, IgM antibodies to hepatitis E virus are positive. Does not usually cause chronic disease. A vaccine is currently in development, but is not yet in widespread use. Thank you for watching. For more videos, subscribe to our channel.
Application in medicine. Ribavirin as monotherapy may be effective in the treatment of chronic HEV infection. A 3-month course is meant to be inappropriate during the therapy for most patients. Pros and cons. At the time that ribavirin therapy was initiated, 34 patients had had persistently positive tests for serum HEV-RNA found at least 6 months. 12 patients had viremia for 2 less than 6 months, and 5 patients had been infected for less than 3 months. Institute apply in Ecuador. Every year there are an estimated 20 million HIV infections worldwide, leading to an estimated 3.3 million symptomatic cases of hepatitis A. Conclusion: Ribavirin as monotherapy may be effective in treating chronic HEV infection. A 3-month course seems to be inappropriate during for this therapy, though a lower therapy can be given to heavily immunosuppressed patients and those who still have viremia 1 month after the initial of therapy. However, prospective studies are required to determine the most beneficial dose and duration of ribavirin therapy. Thank you.